use the index finger of your non-dominant hand to palpate the membrane through the incision. Once the membrane has been located, make a stabbing horizontal incision through the lower portion of the cricothyroid membrane. Temporarily place your index finger into the stoma to maintain a firm fix on its location. Next, place the tracheal hook into the opening in the membrane. Rotate the hook cephalad and pull it gently toward the ceiling to snare the inferior aspect of the thyroid cartilage. While holding the hook with your non-dominant hand, use your dominant hand to place the trusodilator into the trachea. Spread the blades open to dilate the opening in a vertical direction. You are now ready to insert the airway into the trachea. If an assistant is available, he or she should insert the airway while you maintain control of the tracheal hook and the dilator. Insert the airway into the trachea so that it is oriented in a plane parallel to the trusodilator. Then, rotate the dilator and the airway together 90 degrees while advancing the tube further into the trachea. Advance the airway catheter completely so that the flange of the device rests against the patient's neck. Once the tube has been fully inserted, you can remove the tracheal hook and the obturator from the airway catheter. Finally, inflate the cuff with air and begin to ventilate the patient with a bag valve mask.
That done a couple of times. Okay, so nasal tracheal intubation, we kind of talked about that a little bit, some of the disadvantages, sinusitis, it's more comfortable for the patient. Although we never nasally intubate if patient has any kind of a head injury. So they were in a car accident, we don't know if they have a skull fracture or not. If they have a skull fracture and you put a tube in, you could put it into the brain. So we never nasally intubate. If there was any kind of a thought about having a head injury, we would orally intubate, okay? And I kind of showed you guys how to do this. So around 26 to 28, for nasally taping it at the nair, okay, because it's going to have to go in much farther. You have more of the tube going in because you have to get down to the oropharynx, okay? And you know what the McGill forceps are for. And there's the McGill forceps, advancing the endotracheal tube into the trachea. Okay, so here's your trachea. See how anterior it can be? So when you put the patient in the sniffing position, it kind of opens it more in a direct path for you to put a tube in. Here is your esophagus. So you want to make sure you're getting it through the cords into the trachea. Okay? So complications of intubating. If we intubated and we push the tube too far in, okay, going to take the path of the least resistance, right? Why would it go into the right side then easier than the left side?
The angle?
The angle, so left is angled more.
Yeah.
The right side is more of kind of a direct path. So if you insert that tube too far, what are you going to auscultate if you hear the tube, if you think the tube's in the right main stem, when you auscultate, what will you hear? And you're bagging the patient.
Bronchial sound?
Where are you going to hear breath sounds? If the tube is in the right main stem, where are you going to hear breath sounds? When you bag them. You're going to hear them on the right?
Yeah.
Sure, because that's where the tube is. It's in the right? So you're gonna ventilate this right lung. Are you going to hear them in the left?
No.
No, you're not going to hear them in the left. So you're going to have absent breath sounds on the left. You're gonna hear them in the right. So we're gonna pull that ET tube back, right, a couple of centimeters, and now we're gonna re-auscultate. Now I hear bilateral breath sounds. Now I'm 24 at the lip or 23 at the lip. Okay, I'm no longer in the right main stem. Okay, so that's why we have to auscultate. All right, so complications of an endotracheal tube. So, when you have any kind of an airway in your, if you have an artificial airway in the trachea, that's not, it shouldn't be there, right? So your body reacts to foreign substances in your body, number one. Number two, you can have, if you inflate that cuff too high, you could cause mucosal injury, all right? So I put 3 ones here, 3 different injuries that I want you to know, okay? So 3 here, and I've actually written out the definitions for you. So tracheal malacia. Malacia means, and I put the definition for you so you would understand it, softening of the cartilage rings, so malacia. So the cartilage is not intact anymore. It's not firm and in place, creating a patent airway. Okay, it's kind of pliable, all right? So that can be a problem. Tracheal stenosis. Stenosis means narrowing of the trachea, okay? So the airway has narrowed, all right? So that's an issue. Tracheoesophageal fistula. Fistula means a communication or an opening, all right? So you've created, that usually happens at the cuff itself. So if you've overinflated it, you can cause tissue necrosis, okay? Decreased blood flow to that area, and that necrosis can actually erode away the tissue. So now there's an opening between the trachea and the esophagus, all right? Tracheoesophageal fistula. And they would need to surgically repair that, okay? This I don't see very often. These 3 are the most common that you'll see, all right? So they're usually happening around the vocal cords or further down by where the cuff is. Okay, so if you had, let's see, if you had swelling, so it says here, Glottic edema, swelling can occur over 24 hours after extubation. Okay, so if you have a tube, an endotracheal tube, and for a long time, that's an irritant, right? So your body responds to that irritant by creating swelling, right? So if you extubate a patient, and it can happen right away. It doesn't have to happen 24 hours after extubation. You extubate a patient, and you hear, what's that sound called?
Whoozing.
What is it?
Whoozing.
What did you say?
Whoozing, right?
Loud, I can't hear you.
The whoozing?
No. It's upper airway obstruction, upper airway edema. Stridor.
Stridor,
You hear
stridor.
stridor, right?
Mm.
Stridor is what you're going to hear when you extubate a patient. If you have any upper airway edema, you'll hear a stridor. And how do we fix stridor? What do we do? If you have mild to moderate stridor, what do we do? You learned about it I think with the cool mist, right? You do the cool mist aerosol first. The cool aerosol is going to vasoconstrict those blood vessels, decreasing blood flow, which is going to decrease edema, okay? So first we're going to give a cool mist aerosol, all right? We're going to give that first. And what drug can we give if you hear stridor? What drug did you learn about can you give if you hear stridor? Albuterol is for lower airway wheezing, okay? This is up here. What drug do we give for obstruction or edema in the upper airway? Racemic epinephrine. This is before steroids, okay? This is mild to moderate stridor. We're gonna give racemic epinephrine. Racemic epinephrine. What's the dosage we give for racemic epinephrine? same as albuterol. 2.5 milligrams, okay? Same as albuterol. Okay, I don't want you getting into clinical and you have somebody that is having stridor, and you say, and the instructor says, what do we give them? And you say albuterol. Or you say, I don't know the dosage to racemic. You have to know these things. Okay, so racemic is for emergency upper airway edema, because it's going to decrease swelling by vasoconstricting those blood vessels. And it's the same as albuterol, 2.5 milligrams. And we can give up to 3 treatments, okay? And then if that's not working, then we can give a steroid called Decadron. Okay, we can give Decadron, but Decadron takes 4 to 6 hours to work. Okay, so if it's moderate to severe, you might just have to reintubate the patient. Okay? So this talks about a tracheoesophageal fistula. It's tracheal erosion from the cuff and the tube, and they would have to surgically fix it. Okay, so the cuff is really important because that's what's going to cause a lot of the destruction, the tissue injury, is that cuff. So we put the air in the cuff, right? So we want to make sure that it's enough air and it's not too much air. If it's not enough air in that cuff, what can happen? If you don't have that cuff inflated enough in that trachea, what can happen?
Can move, slide up or down?
Huh?
It could easily be removed.
Yeah, so it's not, the tube's not stabilized. That's a great answer. What else could happen? If you don't have a good seal from the upper airway to the lower airway. Upper airway is not a sterile environment. Lower airway is a sterile environment. So if you don't have this cuff sealed, what can happen with the upper airway? Secretions. Can they slide down into a lower airway? Sterility? Yes.
Yeah.
Yes, they can. We have a lot of bacteria in our mouth, right? So, and if you're just laying there, it just pulls back there, and it can just kind of migrate right into that lower environment. So what can happen if you aspirate these secretions that are full of bacteria because your cuff wasn't inflated enough? What is that called when we get that infection in the lower airway? Ventilator-associated pneumonia, VAP. Remember that? Okay, if you don't have the cuff inflated enough, you can get a VAP infection, ventilator-associated pneumonia. If it's inflated too much, you're going to get tracheal stenosis. You're going to get injury. So, we have what's called a low pressure, high volume cuff. Okay, and that's what this is. Low pressure, high volume. So think about, if your boards asks you, which cuff do we use, or do you want to use? This one here is a high pressure, low volume. Okay, and it's putting more pressure on the airway. So I just remember, because I know at the hospital, I remember everybody was arguing with me. They were like, no, it's high, because we had to document it. They were saying, no, it's high volume, low pressure. And I was like, or I'm sorry, it was opposite. This is low pressure, high volume. This was high pressure, low volume. And I said, no, just remember you want low pressure so you're not creating too much pressure on those airways. So this is what we use, low pressure, high volume. Okay, so this is showing you your anatomy. Here's the airway, here's the tissue, and here's our vessels, okay? So a high pressure cuff is going to compress that tissue, compressing blood flow to the area, causing that tissue to necrose. All right? This one here, less pressure on those side walls. Okay? So we want to make sure we're not moving this tube around like crazy because you're going to be injuring. You know, if we're moving it around or just not being careful, that's moving inside inside. So we need to be careful with that too. So you're gonna limit your tube movement. Make sure you don't put a size 9 in a female, right? That would be crazy. Maintain acceptable cuff pressures. Not too low, not too high. So, this is important here. So, normal perfusion pressures, that means the capillaries in the airways, okay? Capillaries in the mucosa are about 20 to 30 millimeters of mercury. So, you don't want anything higher than that, because then you're going to be obstructing perfusion to that tissue. All right? So that is capillary pressure, 20 to 30 millimeters of mercury. So we're going to stay between 20 to 25 millimeters of mercury for our cuff pressure, or 25 to 35 centimeters of water pressure. So we have two different ways to measure. When we use a cufflator, I don't know if I have a cufflator back here. Let's see if I have one. I'll look for one. I don't see one right now. But when we use a cufflator, and I'll show you what it looks like, we measure in millimeters of mercury, okay? If you were to use like a blood pressure cuff, we can measure it differently. But for your boards, you need to know both of these numbers for your boards, okay? So with a cufflator, we're gonna be keeping that cuff pressure 20 to 25 millimeters of mercury, okay? We want it less than the capillary pressure of the tissues. All right? So here it just says excessive pressure is going to decrease lymphatic flow, which is going to cause edema. What do lymphatics do? What's your lymphatic system do?
Get rid of interstitial fluid?
Yes, it removes excessive fluid in the tissues. Yes. So if you're occluding them, you're not going to be able to remove that fluid, and it's going to cause swelling in the airway. If you can't get rid of fluid in the tissues, you're going to have swelling. Okay? Decrease venous flow. Does that make sense? Okay, excessive pressure. The venous system pulls fluid away, right? Arterial brings oxygenated blood to the tissues. Venous takes it away. Well, it's not going to be able to take it away, and that's going to cause edema. Okay? You're not going to have as much arterial blood flowing to the area, so less oxygen to the tissues, causing necrosis. And if you allowed high pressures on your cuff to maintain for a certain amount of time, you could cause what's called a tracheo-innominate artery fistula. That's a bad thing. Okay? That's from having too high of cuff pressures. All right? When the patient goes to the operating room and they come back, you know what anesthesia does? They just shove in 20, 30, 40 cc's of air until they just keep shoving it in. And that's fine while they're in the OR, but when they come back up to you, you want to do a cuff pressure immediately, because you're going to take out probably half of that air. Because you need to maintain it for a certain amount, right? We need to maintain it between 20 and 25 millimeters of mercury. Okay? So, let's talk about this tracheo-innominate artery. All right, so this is a little anatomy here. So here's the trachea. Here's your thyroid gland. Okay, there's the vein, jugular vein. There's the carotid artery. Okay, and here's the innominate artery. Do you see how close it is to the trachea here, where the cuff is going to be sitting? It's right here. Okay, so if that cuff is overinflated here, it can put pressure on the tissue and the innominate artery, and it can cause a tear in that artery. So if that happens, I've seen it happen one time. They called a rapid response, and this guy had a tracheostomy, and blood was just pouring out. And the intensivist was already there, There's nothing they could do, and he died, because he bled out. They couldn't do anything. So this is what I'm gonna teach you what you can do, okay, to try to stop the bleeding. So if that was to happen, so we're gonna prevent it, because we're not gonna have that cuff pressure too high, right? So we're gonna prevent that. But if it did, if you don't do anything, the patient will, does anybody know what that word is? Exsanguinate. They're gonna lose all their blood volume. They're bleeding out, exsanguinate. Okay, so the first maneuver we wanna do is, see here, this is an overinflated cuff pressure, the cuff has been overinflated. If you start seeing blood pouring out, you're gonna increase that cuff pressure even more, okay? Because you wanna occlude, see this is the innominate artery right here? So if you increase it even more, it's gonna press it, compressing it so that you're occluding it. It's like putting a tourniquet on until the surgeon can get in there and fix it, okay? So that works most of the time, all right? If that doesn't work, then the other option is to try to put your finger into it and compress the innominate artery with your finger. So put your finger in the trach and compressing that artery. It's right against the wall here. So you would just hold that, and you would have to hold it until as you're going down the hall to the OR, okay, to try to stop that bleeding. All right, so in my 30 years, it's only happened to me once. I think Nina's seen it a couple times. Because that's pretty scary, right?
Yeah.
It's very, very scary. So surgeons would just have to cross clamp this, and there's the tear, there's the fistula, and they would have to repair that, okay? Pretty scary. All right, so when we do a cuff pressure, I wanna see, okay, there's the cuff later right here. This is the cuff later. See that? Will you be able to write that if you see that picture on a quiz? Cuff later, okay? Just made up y'all's quiz yesterday, all right? Cuff later. That's what that is. You'll have to say what some of the airways are, and that's that one you'll see too. That's a cuff later. Okay. So, two different ways that if you didn't have a cuff later, all right? Sometimes, like at the hospital, they might have one cuff later, maybe they're broken. The optimal way to measure your cuff pressure is to use the cuff later, and that tells you exactly where your pressure is, okay? So that's the best way to do it. But if you don't have a cuff later, then these are two other ways that we do it. And one is called minimal occlusion volume or minimal leak technique. When I was a student, we used to do minimal leak technique. We no longer do that anymore, and I'll tell you why. But it's still on your boards, so you have to know what it is, okay? So minimal occlusion volume is done like this. So minimal occlusion volume is, I would have my stethoscope out, and I'm gonna listen. Grab a stethoscope. Okay. So I have my stethoscope out. So I'm gonna do a minimal occlusion volume. That's what we do in clinical. If we don't have a cuff later. And we do it once a shift to all of our patients who are intubated. Trach patients, endotracheal tube patients. So I'm gonna listen. I'm not putting them in my ears because I didn't clean it. But we're gonna listen here, right where the cuff is, right? Right in the neck, where the cuff is. Okay, so we're gonna listen here, and we're going to release. As we're listening, we're gonna release enough air out of that cuff, okay, until we hear a leak, gurgling. So we hear a leak. It's not sealed anymore. There's a leak, okay? So we want just enough pressure to seal that leak. That's it. We don't need any more pressure than that. So I hear a leak, and I say, okay, I hear the leak. I'm listening with my stethoscope right over here. So I hear a leak, I hear gurgling, and I put just enough air back in to seal that leak. The leak's gone. And I say, okay, I just did a minimal occlusion volume check, okay? I put just enough air in there to seal that cuff so there's no leak. The minimal leak technique is you would create a leak. You would create a leak. Hi.
This is Louise.
Hi, Louise.
From-
Nice to
we're
meet
gonna
you.
work on our servos.
Perfect.
For half of our first year students.
Perfect. So you would create a leak. I hear the gurgling now, so I know the cuff is not sealing that airway, okay? Before you do this, what do you think you want to do to the back of the oropharynx? What would you like to do? Before I let down that cuff,
The younger
you're going to suction all that out because you don't want that just sliding down the back into the lumps. You're going to clean that out, right? Clean all that out. So minimal leak technique, we're removing air till we hear a leak, okay? And then we put enough back just so we can still hear a leak. It allows for a leak to be there, a minimal leak, okay? That's what minimal leak technique is. But we don't do that anymore. Why don't we do minimal leak technique anymore? Why do you not want to have a leak? Jamie Lola. Why don't you want to have a leak in the cuff? Why seal it just enough so there's still a leak between the upper airway and the lower airway? I need you to give me something, some explanation. You gotta think of something. Huh? You gotta talk really loud.
Oh, can you repeat what you said?
I said, why would I want to do a minimal leak technique? What is a minimal leak technique?
So like when there's a leak, you wanna block it.
Yeah, but how do you do a minimal leak technique?
You use stuff you use the air to block it.
How did I just do the minimal leak technique? Huh?
You oxygenate it.
No. Does anybody know how I just did the minimal leak technique? You can tell Dan Lola.
To allow just a little bit of the oxygen.
So how did I do that? I used a syringe. I used a syringe and I pulled air out of the cuff and I created a leak. I added air back till it was just a minimal leak, right? And I'm asking, why do I not want to keep a minimal leak, Demi Lola? Why do I want to not keep a minimal leak? Why do I want it sealed and I'm going to do the minimal occlusion volume? What happens if you allow there to be a leak? You can ask somebody if you don't know. No, let her, she's gonna ask somebody. Who would you like to ask? Who? Shown?
Does like try to prevent infection?
Right. So, but the secretions can just slide down that airway from the upper airway where it's not sterile to the lower airway where it is sterile. And what can it cause? If you let secretions, it can cause a VAP, ventilator-associated pneumonia. Okay? So, do we use minimal leak technique in the clinical setting? No, we do not. We only use minimal occlusion volume. Okay? Okay, this is your cuffulator. This measures in millimeters of mercury. What do we want to keep our cuff pressure at in millimeters of mercury?
20 to 25.
25 to?
20 to 25.
20 to 25. And what about in centimeters of water pressure?
25 to
Good,
35.
25 to 30, good. Good. So troubleshooting, all right? Troubleshooting problems with the cuff. If the cuff pressure registers 0, so you take your cuffulator and you're measuring it and it says 0. One thing is maybe you don't have that spring, that valve compressed enough. Okay, so that would be one thing. Check the connection between the manometer and the pilot balloon to tighten it. Maybe it's not in there tight enough. If air is inserted and there is still evidence of a leak, the cuff is ruptured, what do you have to do? You're gonna have to extubate and get another tube, okay? If the cuff pressure exceeds that which is recommended, all right, if you keep having to add air in and you still have a leak, and you're way higher than your safe cuff pressure range, then the patient might need a larger endotracheal tube, okay? If the cuff pressure is measured at a specific peak inspiratory pressure, PIP, peak inspiratory pressure, but the PIP subsequently changes, then remeasure the cuff using not a cufflator, but you do the MOV method, okay? All right? Any questions about measuring the cuff? Do you see the importance of keeping that cuff pressure measured? Okay, we don't want to cause any VAPs. We don't want to cause any erosion of the tissue. Okay. So we used to tape with cloth tape, but now we use holders. The holders I showed you, and those are our holders. They're very nice. Questions about intubating? Huh? The manometer? The cuffulator, you mean? It's a cuffulator. The cuff pressure registers 0. Manometer, that's the cuffulator. Cuffulator is also called a manometer. The cuffulator, it's a manometer. It measures pressure. Okay. All right, and I'll look for one in a minute. I think there's one. I think we have one back there. Okay. So different types of endotracheal tubes. Okay, let's see. We have a double lumen. I'm going to pass these out to you guys. I have 2. So you can just pass that one back and you can look at that one and pass that one back. So this is called, you have to know the names of this. Okay, so a double lumen, lumen means these ports, lumen, okay? It's a tube, is a lumen. So double lumen means there's 2 ports to this. All right, this is a double lumen, okay? So it's also called, it can also be called an endobronchial tube, okay, or a Carlin's tube. Dr. Carlin's created this in 1944, all right? So that's a name brand, so you're going to use that on your boards. You will not see Carlin's on your boards. But you could either see double lumen or endobronchial tube. So if I ask you to name this tube, you could say double lumen, you could tell me Carlin's, you could tell me endobronchial tube. You could say any of those and that would be correct on your quiz, okay? All right, so the way this one works is it has two openings. Can everybody see this? So there's one opening here, okay? And there's another opening right there, okay? So this one fits in the trachea, this one fits in either the right mainstem stem or the left main stem. And they'll use an endobronchial tube if they want to independently ventilate different lungs. So let's say the patient has right lung cancer, and they want to operate. Maybe they want to do a pneumonectomy. Okay, so they want to collapse that lung down so they can work on that lung. All right, so they can independently do that. All right, they could angle this towards the right, towards the left. All right, and you can blow up these balloons, these pilot balloons. I mean, it even says it. Can you pass? Did you pass this back?
Yeah.
Yeah, everybody seen it? So you see on here where it says, one says tracheal, the other one says bronchial. So this one would fit in the tracheal, okay? The tracheal would be this opening right here. And this one, bronchial, is gonna be here. So you would blow up your balloons. There's one for the tracheal and one for the bronchial. So if I was gonna have, my patient was gonna have a right pneumonectomy, then you would place this tube, angle it, and place it into the left main stem, right? And you would not allow ventilation to go to the right, all right? So you would only ventilate, you would hook up ventilation, a ventilator to the left, and independently ventilate both lungs, okay? So you could shut down ventilation to the right and just ventilate the left. Or, let's say you had a patient who has a bad pneumonia, right? And you have a bad pneumonia on the right, so you want to ventilate these patients differently. You want to ventilate the left lung with less pressure, not to injure the left lung, and the right lung you need to ventilate differently. So you could hook up each tube to a different ventilator to independently ventilate both lungs. Pretty cool, right? Okay, so that's a bronchial tube and a bronchial tube, or a Carlin's tube. We always call it a Carlin's tube, but you would see it on your boards as one or the other here. And that just shows you the orifice here that sits in the trachea, and this one sits in the main stem, okay? And that's a picture of it. I just added that picture so you can see what it looked like. So you can see it, if you see that on a quiz, you can know that there's two cuffs to that, right? There's an opening there and there's an opening here, so you know that's the independent Carlin's tube. Okay, independent lung ventilation Carlin's tube. So we talked about indications. So if you want to independently ventilate each lung, you can do that. Allows for single lung ventilation while the other lung is collapsed to make thoracic surgery easier, okay? So that is your Carlin's tube, or endobronchial tube, okay? This is a CAS tube. Now, we don't have a CAS tube, but a CAS tube stands for Continuous Aspiration of Subglottic Secretions. So this tube's pretty darn expensive. So they don't really have them too much at hospitals because hospitals have to worry about cost. But this tube here has, you have the endotracheal tube, but there's also a side, this side here is hooked to suction. So there's a little orifice down here, there's a little opening that can constantly suction secretions that pull down there. So it's gonna decrease VAPS. So it's very effective. And you're gonna put the suction pressure on about 20 centimeters of water pressure for your suction pressure. And that's such little, and it's gonna be continuous. So it'll continually move those secretions so they don't aspirate into the lower airway, okay? 20 centimeters is about enough pressure to suck through a Coke, like a large gulp. That's about how much pressure that is, all right? So that's gonna really keep the lower airway clean. All right, so it's going to reduce the incidence of VAPS. I put a video on Blackboard for you guys on CAS so you can see it. And some of the videos, as I said, I played them here today, but there's more videos that you can refer to. tube exchangers. You have two kinds of tube exchangers. This is a tube exchanger, but it's not either of those kinds. The ones I want you to know about are, it's called airway exchange catheter and the bougie, gum elastic bougie. That's how you say it, bougie. So anesthesia, if they want to exchange the endotracheal tube, right? Maybe the cuff has been broken, right? And you have a cuff leak, so they need to change the ET tubes. So instead of taking the entire tube out, they'll use a tube exchanger, all right? So the bougie is one that we use all the time. So basically, this is a tube exchanger, okay? This would be a tube exchanger. So what they would do would be, right, you have an open patent airway all the way to the trachea, right now, right? So what they would do is they would place this in, okay, all the way in, and then they're going to deflate the cuff. Well, that's not good. Deflate the cuff, and they're going to pull the tube out while pushing this in. Makes sense? Oh, no, I got a video. They're going to keep this in, but they'll pull the tube out. So now they just have this that's sitting in the trachea. So now they can take another endotracheal tube and feed it through here, right? And actually place it right in, it'll slide right in, because it's got a path. So you're not losing your airway 100%. You still have a tube in. Okay, so that's pretty cool. So, a couple things that I want you to think about here. So this one here is the cook. It's the cook. And these are on your boards, the cook and the bougie. So the cook has a inner diameter and there's a tube here. So you can ventilate through the cook airway exchanger. You can ventilate through this, and there's a 15 millimeter adapter. All of our tubes have 15 millimeter adapters, okay, so that you can attach an ambu bag to a 15 millimeter adapter. You can attach this to any 15 millimeter adapter, okay? All right. So the cook tube has a 15 millimeter adapter, and you can ventilate through it. It's a hollow tube, okay? Cook, hollow. Hollow tube is the cook, so you can ventilate through it. The bougie does not have an inner tube, and you cannot ventilate through it. There's no central lumen. Okay, it's angled so that you can put it in and angle it kind of forward, anterior towards the trachea. That's why it's angled. So the bougie is a tube exchanger, but you cannot ventilate through it. So that's the difference between the bougie. The cook has a 15 millimeter adapter, and you can ventilate through the cook. So I need you guys to know the difference between those two. Okay, Nina, we're just about done.
Yeah, they can take a break then after that.
What time is it?
Well, it's probably
10:30.
10:30.
Oh, good, so that's not bad. Did you send me a student's
No,
link?
not yet. They're a little freaked out. Totally freaked out.
Are they?
Yeah, it's just overwhelming. And now they're scared because they're taking the TMC exam.
Oh, they're taking it right now?
Yeah, so I'm just gonna let it go. But I will send it to you.
Okay, thanks.
Definitely.
All right, so this is the bougie, all right? No central lumen, doesn't have a 15 millimeter adapter. You cannot ventilate through the bougie. Let's see, I got a little video. Let's check it out.
So we're gonna do it on, try with the 7.0 right now. Is it okay enough to, going up half size?
Yeah.
It seems to have a constant air leak in there, so. Work fast.
Is it a code?
The balloon's down, yep, balloon's down.
The bougie. Yeah, ventilate through it. And now they still have a patent airway. Until they slide it right
Hey,
over.
lubricate up the balloon just a little bit. Do you have some hay white? Okay. Yeah, just.
Right into the trachea, right through the pores. It's just looking.
Oh, yeah. Yeah.
Is it working now? Hallelujah.
How about that? That's a nice guy to help them intubate, right? All right, which one can you ventilate through?
The code?
The cook. And the other one is the bougie. Good. That's it. Hey, I didn't tell you this on the, this is an adapter for your endobronchial tube here. And you can actually hook these both up to this and ventilate with just one ventilator if you wanted to, okay? But I showed them I handed it out. All right, guys? So it's 10:30.